Our job is to try and keep people from being admitted to acute settings. So we can get referrals from paramedics, from GPs, from patients themselves, from relatives, from social services. And we get a lot of acute and chronic conditions. We get some chest infections, cellulitis, UTIs, a lot of fallers. We also do front door at the hospital, so we work in Kettering and Northampton. So we assess patients that come into A&E and see which ones we can get out if possible. We have nurses on the team, we have therapists, we have RAs, RTs. Recently got a pharmacist who do medication reviews in the community. We've also got CPNs and consultants for medical advice, and sometimes they can go out and see patients and put in a plan for those that are well as well.
Okay, we also do IV antibiotics in the community, so in patients' homes. There's just a quick overview of the patients that we take. We do cellulitis, UTI, post-op infections, acute and chronic long-term conditions, diabetic foots. We also take a lot more than just that. So with that, they have to have their first dose in the hospitals. So we normally take from Kettering and Northampton, but we do have patients from Coventry and Oxford as well who just need IV antibiotics. And obviously the maximum we take is 3 times a day, and we go in, do their antibiotics. Now, the benefit of having your IV antibiotics at home is you're going to recover quicker, you're mobilising, you're in your own environment. So the evidence out there does show that it's actually better for each patient. And also with the IV antibiotics, we have patients, from I think 18 up till 90. I think we've just said there's about mid-90s we've had on IV antibiotics. So obviously it prevents a hospital stay, so it costs less, and the benefits of the patient. I'll go on to the evenings.
Yeah, so we also offer an evening district nurse service, which is a service we work from 5 till 1 a.m. in the morning. We get referrals from 111. For instance, if let's say a call's come through someone with a blocked catheter, rather than having to send an ambulance crew out, getting the patient into hospital, then waiting 4 to 6 hours to get a catheter changed, we can go out, we can change it and avert a crisis. We cover a very large, obviously the whole of Northamptonshire, north as Corby and south as Brackley. But also we work alongside the OTs as well, which is Danny, you'll do the assessments of the home and...
So we've got occupational therapists and physios. We work alongside our rehab technicians and our rehab assistants. So generally we do a lot of sort of falls assessments, a lot of mobility assessments, functional assessments as well within the home, see if there's any adaptations or equipment provision that they might require. Things like energy conservation, and sort of achieving those sort of short-term goals, because we are such a quick sort of fast service, if you like. It's what's achievable in the time that we're going to be there. So we're kind of a bit of we throw everything at the patient, try and problem solve everything, and then we pull out because we are just trying to avoid that crisis. So Band 7s, we do the discharge to assess, which is the assessments coming out of hospitals. So we don't actually see the patient until we see them in their own home, and a lot of the times they're being sent home from hospital and they're not medically fit, even though they said they're medically fit. So we have to do a lot of problem solving and a lot of medical input from a therapy point of view as well. When you get there and you're presented with a patient that's got SATs of 79 and they're looking a bit blue and you think, ooh. So we use our AMPs, we use our consultants, and we try and keep them at home if we can. Sometimes we can't and we have to sort of pop them back in, but we do as much as we can to try and sort of promote their independence and make them safe. You can't sort of avoid all risks in the home, but you can try and signpost and identify and make them as safe as they can. So our physios do a lot of chest work, so we do a lot of sort of exacerbations of COPDs. We've got rocket team that we can refer on to. We do, what else do we do? Energy conservation, I think I said that. We use our rehab techs and our rehab assistants to sort of promote the exercise programs that we might put in, or to help with meal prompts and things like that. sort of doing cognitive assessments as well, just to identify what needs to be highlighted, and actually, is this patient going to manage long term, or do we need to sort of think about putting a package of care in? So generally as an MDT, we're a big team, but we can do quite a lot, quite a sort of fast, rapid response. I think we've got a 4-hour window. The patient's referred into us, we have to go out in 4 hours. So a lot of the times we're quicker than getting hold of the GP. If people become unwell, if you've got a family member that becomes unwell and they need that sort of short, fast response, often we're a lot quicker and a lot more successful in problem solving and getting everything sorted. So I don't think people know about us quite as much as they should do, but I think we can probably save a lot of money for the trust and for the acutes as well, because we're keeping them at home, so we're a lot cheaper than sending people into hospital. So.
And when we do send them into hospital, we track the patients, so patients are tracked for a 72-hour period.
Thank you.